thank you all so much for joining us at our Public Health Discovery Seminar Series. My name is Cassietta Treywick. I'm one of the admission counselors here at Tulane University School of Public Health and Tropical Medicine. And today I have the honor to introduce Dr. Eva Silvestre, who will be presenting language access in healthcare settings. And so if you have any questions, please drop them in the Q&A chat. And I would definitely read them out to Dr. Silvestre after her presentation. Again, thank you all so much for joining us. And Dr. Silvestre, I'm going to let you start.
Thank you. And Cassie, they can drop the questions in and you can interrupt me throughout. I don't mind that at all. So we don't have to wait till the very end if there are questions. Okay. So thank you again. Good afternoon, good evening. I don't know where y'all are. So all the greetings to you. As Cassie said, my name is Eva Silvestre, and I am a professor in the Department of International Health and Sustainable Development. And I'm going to go ahead and start sharing my screen with y'all. And I'm very excited to be able to talk to you about this topic that is very personal to me in a lot of ways. It's just something that doesn't get enough attention, in my humble opinion. And it's this issue of language access in healthcare. And when we're talking about language access, we're talking about people's ability to be able to communicate with their doctors, with the nurses, with people in general, when they're interacting with the healthcare system. And so I just want to start off with a little bit about me and why this is such an important topic to me is because I've lived this experience myself. I was born in Guatemala, and we moved to the U.S. when I was 8 years old. And our family came to the U.S. seeking political asylum. And you can see here, this is the actual picture from our family passport with my mom and my siblings when we came from Guatemala. My father was already living in the United States because he left first. And so he was already here in the U.S. when we moved. And as often is the case with immigrant families, children learn the language first. And so I picked up English fairly quickly. I don't recall there ever being too much of a struggle for me when I came and I was in second grade. But it took my parents a little bit longer to learn the language. And so I spent a lot of my childhood and adolescence being my parents' translator and interpreter. Right. And so this is something that like I said, I've seen in action, and I did interpretation for them, on everything, whether it was like for their job in healthcare, for our school, for our immigration case. That was my story as well. And this also meant that we were undocumented for a time. So we struggled with accessing healthcare. This is something that I often tell my students is that I personally did not have health insurance until I was in college, because as many of you know, colleges and universities require you to have some sort of health insurance before you can enroll. But my parents just didn't make enough money to include us in the insurance that they got through their job. So I was uninsured until I was 18 years old and went to college. I also like to say that I'm a first generation student. I'm very proud of that. I'm a proud Pell Grant recipient as well. I speak Spanish. That was my native language. I also identify as a fat woman. I think that's another way that, that it affects how I move through the world. And I'm also a proud single mother of a 9-year-old boy who you can see here in this picture. And he'll come up again because I've also had experiences with him and language access in a research setting, but a really important research setting that I really want to be able to share with you. So again, this is just, again, like a little bit of background about me and why I feel very passionate about this issue of language access. And as I mentioned before, too, I'm in the Department of International Health and Sustainable Development. And so language access is something that I think about a lot as well in terms of our international research, because we're often working in countries where English is not the primary language. And so we have to think about and spend time translating documents, everything that we do with our projects into the local languages that are spoken. We, often have to do, use interpreters for our own interviews and our data collection, et cetera. So language access in international settings is it's part of the job. It's part of the work. But what I'm really going to focus on here, though, is language access in U.S. settings, and particularly in healthcare settings. But to get us ready, I actually want us to listen to a snippet of this podcast. And this is one of these NPR podcasts called The Pulse. And this particular segment aired in December, just a few months ago. And it was kind of covering a whole bunch of issues in terms of lowering barriers to care. But they bring up this issue of language access. And so I really want us to listen to that before I get going into my formal presentation. Because I think you were able to get like a good kind of taste of the challenges that you can find if you're not able to communicate with your provider. And here in this case was the confusion of the term depresión, which is depression, and la presión, which is the term that we use for blood pressure, right? And so someone got the wrong medication. So let's think about that, keeping that in mind. And I also, again, wanted to say too, that I also really relate to both the person being interviewed and the interviewer in terms of having had experiences with their families when they were the main translator, interpreter, knowing lots of information that you as a child probably shouldn't know about your family and their situation. And also my mother, who, may she rest in peace, passed away in 2019, also had a lot of chronic health conditions. And I also have these images of her sitting, trying to figure out her health insurance and what medication she's supposed to be taking and all of that. So this is, again, all really, really speaks to me. So when we talk about defining language access, though, we're talking about providing people who have limited English proficiency. And that is the term, sometimes you hear the acronym LEP, but that's what we're talking about, is people who have limited English proficiency. And so language access means making sure that they have reasonable access to the same services as English-speaking individuals. And to some statistics, right? So language access includes also not only foreign languages that are not English, but also for people who are hard of hearing. And so about 48 million people in the US have hearing loss, 57 million people in the US speak a language other than English. And there's, over 322 different languages that are spoken in the United States. And when we're talking about language access, it's, as I mentioned before, it isn't just one area, but really language access needs to be considered in many different areas. And I used to be a member of the Louisiana Language Access Coalition, and they worked in three kind of big bucket areas, right? So language access in health, which is what we're going to talk about, but also language access in education, and then also language access in justice. And so this is when individuals are encountering the criminal justice system, whether it's through criminal, because of crimes, because they're victims of crimes, because they're potential perpetrators of crimes, but also in immigration court, right? So language access is something that we need to consider in all these different arenas. Now, language access, so what does it include, right? It includes interpretation services for spoken interactions. So this is like if you're talking to someone to make an appointment or to get information about where to go or get your refill, talking to your doctor. But then it also means the translation of signs, forms, health promotion materials, documents such as those that are referred to as knowing your rights, which again, clinics, hospitals have to post so that people are aware of what their rights are. All of that has to be translated to various languages. And this is an example. And this is a picture I got it's an NPR story from a couple of years ago, 2022. And there was an outbreak of polio in New York. And so this was just a snapshot of information that was presented and translated for the different communities in this particular part of New York. And so here they, they created and provided information about polio transmission in the main languages that were spoken in that particular part of New York, which included English, Spanish, Haitian Creole, and then also Hebrew. And so they provided the same information and then distributed it to make sure that all of their community members were aware of the dangers of polio and how you get polio and how you should get vaccinated for polio. I should say too, like this was a kind of a really big deal because we had been working towards polio eradication But because of, kind of declines in just kind of childhood immunization rates in some particular communities, we're starting to see some of these diseases that we thought were eradicated kind of start to pop up. You might have heard about, maybe measles outbreaks. This is all kind of similar kind of patterns that are leading to this. So again, just an example of the, translation of materials so that everybody can access this information. We also saw some of this during the outbreak, the kind of the peak of the COVID pandemic, where it was necessary to disseminate information in various languages so that people would be aware and have knowledge about where to go to get vaccinated, et cetera, during the COVID outbreak. So again, language access includes spoken interactions as well as the translation of different materials. So again, here just a little bit of information about the languages that are spoken in the US, and this comes from the US Census. And so we're looking at the top 10 languages spoken in the US, which include English and Spanish and Chinese and Tagalog, which is a language spoken in the Philippines, Vietnamese, which we here and where we are sitting in New Orleans, there are quite a few Vietnamese speakers here, French and French Creole, Arabic, Korean, and German. Those are just the top 10. There's also multiple other languages that can be spoken at any particular region. And you can also see here from this particular map, right, just areas that have kind of higher percentages where people identified through the census that they speak English less than very well, right? So that's where we might have more people who are limited English proficient. And this includes, parts of the, big parts of the Southwest, which is probably not a big surprise, parts of South Florida. Again, these are, areas that receive a lot of immigrants into the country. But then we also have some places out here in the kind of Pacific Northwest and even in Alaska, right, where people are speaking other languages other than English. So again, there's a big variety across the country in terms of the percentage of people who are limited English proficient. And so then when we're talking about barriers to healthcare and being a limited English proficient individual, I tried to just kind of come up with all the different ways. And this is not exclusive. There are probably other ways in which not being proficient in English is going to affect your ability to seek care. But these are just some ideas, some examples that I came up with. The first one is making up an appointment, right? So if you are unable to speak English and no one speaks English at the clinic where you go to or where you call, then you're going to be very challenged in terms of making an appointment. And then there's also the registration, right? Everybody, I'm assuming everybody here has gone to the doctor's office in the US, and you know that when you get there, you have to complete a lot of forms. Some of them are about insurance, but some of them are about your kind of past history, your medical history. Some places are now doing like depression screenings. So there's a lot of forms that are included in the registration packet. And again, if you're a limited English proficiency level, then you're not able to, you're going to be challenged with the registration forms, right? And then at the actual appointment, when you're trying to talk with your clinician, this is going to be challenged as well if you're not, if you're not mastering the English language. And then also the health education component. So, there's different types of health education that occurs throughout a medical encounter, right? So you might get health education when you're waiting waiting to be seen by a clinician. You might get health education from the clinician themselves when they're trying to explain to you, for example, how you might have contracted polio, right? This is an opportunity to then educate you about how people get polio, how you can get treated, how you can avoid it, etc. So the health education piece is also going to be really important. And then also just knowing where to find care. Like that is going to be a big piece as well that you want to, that it's going to be a challenge to you if, most of the messaging is done using, media channels that are not the media channels that you listen to. One example of this was that during the kind of peak COVID, after vaccinations had come out, one of the local medical care systems in the area really wanted to increase the participation of Latinos, Latinx people in vaccination. And so, we were asked to help them conduct some research, do some focus groups with, the Latino population in the area to see what were some of the barriers to getting vaccinations. And, people were expecting a lot of this kind of misinformation and hesitancy, et cetera. But the first few people who contacted us to participate in the discussions didn't actually want to participate in the discussions. What they wanted to know was where could they go to get a vaccine? And so just one of the big kind of gaps that we found was just that we were just not targeting this population where they were, right? So that they were not getting the information. So finding where to go, where to seek care is also going to be limited. Then, of course, like most doctor's appointments can have lots of lab tests and follow-up. So that's also going to be an issue for you if you are not mastering English. And then also understanding your bill, right? Like the bills don't usually come in other languages. They come in English. And if you can't read English very well, that's going to be a challenge for you in order to be able to understand the billing. So then we know, though, that language barriers reduce patient satisfaction with their encounter. Language barriers also decrease the quality of healthcare because we're not able to get the full picture of what is going on with a particular patient if we're not able to communicate well with them. And so we know that there's a clear link between language barriers and poor quality in healthcare. And we know that this link can be broken with the use of qualified interpreters. And so, as we will see, a qualified interpreter is not your minor child. It wasn't me. I was an unethical interpreter for my parents. We didn't know any better, but that's basically what I was. So for qualified medical interpreters, they need to have very specific, competencies, and this includes having language proficiency in both the source and target language, the ability to interpret effectively, accurately, and impartially, be proficient in medical vocabulary and terminology. Now, this is a big area where people, who are bilingual or trilingual, you might be bilingual, but you may not know all of the correct terminology for medical terms, right? And so then that doesn't then make you qualified because you don't know all the medical terminology. And then we also need interpreters to adhere to an ethical code of conduct, right? And this is something that, again, we're not going to be guaranteed if we're using informal interpreters, whether it's a family member, whether it's a friend, whether it's your neighbor. So this is an important component for reducing, the barriers that we have for language access is that the importance of having true qualified medical interpreters. And so here's just some examples of a code of ethics for interpreters in healthcare. And again, I just want to show this because I really want to be able to stress the difference between an informal interpreter and a formal professional interpreter. So here again, interpreter treats as confidential within the treating team, all information learned in the performance of their professional duties, right? So this is, again, you don't want the private information that someone is sharing as part of their medical appointment to then be, shared with somebody outside of that room, right? So you don't want your neighbors, maybe your family members, your friends to hear this. And so a medical interpreter is going to keep this information as confidential. Interpreter strives to render the message accurately, right? And this is, again, something that is very hard to do when you're interpreting for a friend, is that you may want to, you're like, oh, that's really kind of bad news. Let me try to soften this blow by, kind of changing a little bit the way that this was said. Again, that is not a professional interpreter. That's not what they would do. Again, also interpreter strives to maintain impartiality, refrains from counseling, advising, projecting personal biases or beliefs. Again, maintaining boundaries of the professional role is going to be important. Interpreter treats all parties with respect. And then, the interpreter can interact and can advocate for the patient if there's a need, if something happens, right? So that is always possible as well. The other piece too is that interpreters have to continuously improve their skills. And so they have to be part of, different continual education programs in order to improve their skills. Again, these are all things that an informal interpreter would not do or is not doing, right? So this is, again, the importance of having medical interpreters. Now, legal requirements for interpretation We know that the main legal basis for language access include the Title VI of the Civil Rights Act of 1964, which prohibits discrimination based on national origin, right? And so as they mentioned in the podcast, not being able to provide language access is a form of discrimination, right? Because somebody is not able to fully take the benefit of whatever services that you're trying to give. And then in the 2000s, there was another executive order which affirmed Title VI's language access requirement and outlined additional requirements. And so this is the responsibilities of healthcare organizations. And this is in particular for healthcare organizations that receive federal funding. And they're required by law to provide interpreter services for people who have limited English proficiency, but also for people who are hard of hearing or deaf, right? So this is their responsibility if you receive federal funding. And so they also must provide competent and qualified interpreters. And we'll talk about the differences, that there's different categories that fall into this. And also expand services to include family members or spouses. So that means that if you come in and your patient has been very badly injured in a car accident, or they experienced a stroke and they're not conscious, but their family member comes with them, their husband comes with them, their wife comes with them, and they also do not speak English very well. That means that you also need to be able to provide interpreter services for the family member, right? And so they also have to post notices of non-discrimination in the state or the hospital's top 15 languages. And so in terms of the interpretation, who can be the interpreter? Ideally, right, is we would like it for it to be like an in-person interpreter, but that's not always possible, particularly when you're talking about the full extent of the languages that may be needed, right? And so, but specifically, the section prohibits the use of a patient's minor children. So again, we should not be using children as interpreters. Also, adult, family, and friends. The only exception is if the patient refuses an interpreter. Providers may still utilize an interpreter if they determine that the family or friend is not able to really interpret adequately. And the other part too is that you're not supposed to use bilingual staff, right? So just because someone speaks Spanish in your office, that does not make them a qualified interpreter. They have to also go through special training in order to become qualified interpreters. And it has to be part of their assigned job duties. So it just can't be like, hey, can you just come over here for a second and help me interpret for this particular patient? So let me just go back here, because I just wanted to talk about the different types of video interpreters. So I said the ideal is to have in-person interpretation. But this is not always possible. You need to be able to, you need to kind of schedule that in advance. But what other healthcare systems are using more and more now are telephone interpreters and also video interpreters. My son, who's 9, broke his toe a couple of weeks ago. And so I had to take him to the Children's Hospital here in Louisiana for the orthopedist, to check out his toe. And I actually witnessed some video interpretation happening at the reception desk in the x-ray, where they have these, kind of machines that they can, kind of phone in or teleport in a interpreter who's right there between the patient and the provider, and who can interpret it. And you can see their faces because it's a video. So we're seeing a lot more of that. And again, not only because it's hard to have interpreters in all the different languages, but also just because it's just hard to have that many people on staff for interpretation. So again, most people prefer to have the in-person interpreter, but we do have, technology is helping us in terms of developing different ways to have interpretation.
So, Dr. Silvestre, we have a question in the chat. Can providers be certified to give care in their patient's language?
Yes. Yes, they can. They have to go through their own training, but yes, they can do that. But again, that's a really good question, because you will have people who are maybe, immigrants themselves, or they speak another language and they're like, I can do this. But again, you also need to follow the same kind of ethical standards and the training to make sure that you are able to do this. That's a great question, because I often get that question. So yeah, so we know that language access in healthcare settings is very challenging. But we also have to think about language access in our research. And I mentioned before that in my most of my research that has been done internationally, we think about language access all the time. But here, we also have to think about language access in research here when we're doing research in the US. And so people who are limited English proficient are underrepresented in clinical research. We know this, right? And there's a lot of barriers to participation in clinical research. We also know that, communities of color in general are underrepresented in clinical research. Women are underrepresented in clinical research. So, and one of the issues is that, we have to be able to kind of build relationships with communities, and to be able to recruit them in a meaningful way, we need to be able to, again, meet them where they are in terms of language access. But investigators often cite that it's too difficult, it's too expensive, in getting consent, right? So if anybody's going to be enrolling in clinical research or any kind of studies, they need to provide what is referred to as informed consent in order to participate. And so they feel that it's just too difficult and it's too costly to translate all those forms into other languages, hire extra personnel to make sure that the people understand the study and their participation in the study and all of that. And that's some of the reasons why people give for why they are under enrolling people who don't speak English. We also have research studies have to go through institutional review boards. And so sometimes the institutional review boards don't press or ask enough questions as to why you're putting a must speak English only as an inclusion criteria in your particular research study. However, NIH policy, so that's the National Institutes of Health, on the inclusion of women and minorities as subjects in clinical research specifically say that women and minorities must be included in clinical trials, and the cost is not an acceptable reason for their exclusion, right? So we can't just say like it's too expensive, it's too hard, we can't do it. And the picture in I told you I was going to come back to my son here. And this is a story of, so here he would have been 7 years old. And this is when the Delta variant of COVID was really taking hold. I don't know if you recall, but like in the first year of COVID, little kids weren't getting really sick. Like we were getting most of the kind of infection rates and, serious infections and mortality was really kind of focused initially, right, on older populations. And then once the different variants started to come out, we started to see that children were being affected as well. And so this is again, this would have been, like I said, in 2021, and they're starting to do the pediatric trials for COVID vaccine. And so I wasn't sure about it, but then once I saw that kids were really getting sick, I was like, no, let's go ahead and see if I can enroll him in one of these clinical studies for COVID. And I should say too, as another aside, in terms of the underrepresentation of people of color in clinical research, that a lot of my friends who are white had told me that they could not get their children into clinical studies. Nobody was calling them back. And so I'm like, fine. So I filled out, there was like an online form. And so I filled out the online form. And then they called me within like 15 minutes and they're like, can you bring him tomorrow? Right. So I told you I'm Guatemalan. My son's father is Ethiopian. So when I'm filling out the demographic information on him, he's both Black and he's also Hispanic. And they really wanted him because they were under enrolled for kids of color. Right. So I'm like, fine, sure, we'll go. So we get to the clinic site where they're going to do the enrollment into the study, and they give me like a 42-page informed consent form, right? So I have to go read through this form to give permission for my child to participate. But he still has to also assent, right? So someone under the age of 18, for most clinical research, cannot give consent themselves, right? You need the parent to give consent. But they all still have to assent. They still have to say it's okay. So they gave us like a 4-page, kind of summary of the study that's supposed to be, appropriate for his age level. And he was supposed to read that. And then they were going to say, Gabriel, do you agree to be in this study? And he was going to say yes, or he's going to say no. So they gave it to us and it was in English. Like I said, I'm from Guatemala. We speak Spanish in the home. My son goes to a Spanish immersion school here in New Orleans. And they don't start English instruction until the 2nd grade. And so he was in 1st grade. And so I'm like, his English reading isn't great. I'm like, can you give me the form in Spanish so he can read it in Spanish? And it was silence. Like you could hear the crickets. And they're like, in Spanish? What do you mean in Spanish? And I said, you don't have the form in Spanish? And they were like, no. So here we were at a pediatric COVID-19 vaccine trial, right? Then by this point, we knew that communities of color were being disproportionately impacted by the COVID-19 pandemic. They were getting a ton of money to do this research, and they were doing zero outreach to people who did not speak English. I want you to think about that. So this was for COVID. Can you imagine the exclusion of people who don't speak English in other clinical research, right? So they didn't have anything in Spanish for a COVID-19 pediatric trial. So anyway, so the picture here is from when he was psyching himself up for one of the shots. But I say this just to, again, to, make us think about what are we doing? Why are we excluding people who don't speak English in major clinical trials, right? And so this is all going to be related to just, communities of color being underrepresented in clinical research. And that's really going to impact the results that we're going to get. And then it's going to affect the kinds of recommendations we can make when we are, in practice, implementing new treatments, new medications, et cetera. So yeah, so language access and research is another big important area that we need to think about. And then again, this is all part, so language access is part of a larger culturally and linguistic appropriate services standards. And so these are, again, the 15 action steps that are intended to advance health equity, improve the quality, and help eliminate health disparities. So again, I just put this up here just to remind me to tell you, right, that in order to doing interpretation and having interpretation is not enough. Like we need to also think about other broader cultural issues when we're trying to deliver quality care to patients. So then just what are some of the challenges to language access? I've already kind of gone through some of these, like the financial burden of providing services, lack of knowledge about legal requirements. And this is something to, when they've done, kind of surveys of different agencies, they'll report they didn't know, they weren't aware that they were supposed to be providing interpretation and translation services to their patients. The other issue is that there's very few mechanisms to report when you're not getting, language access services in healthcare facilities. These are, oftentimes, people who are, limited English proficient are some of the most vulnerable communities because they can, and they can really be taken advantage of because they're afraid to report, or they don't know how to report, or there's another language barrier to reporting, right? So even when facilities know they're supposed to be providing, translation services, interpretation services, and they don't, there's nowhere to report. Another big issue is just that there's not enough qualified medical interpreters. This is there's a big kind of shortage in terms of having qualified medical interpreters. Sometimes too is the overconfidence of bilingual staff in their proficiency. And as I mentioned, you can become a certified interpreter, but you need to go through the training. Sometimes too, there's still a lack of understanding of how serious language access is in terms of ensuring optimal outcomes for a patient. And then also just kind of a lack of sensitivity towards limited English proficient populations and hard of hearing populations as well. And so just want a little bit more here, especially since somebody asked a question about this. The difference between a qualified bilingual employee and a qualified interpreter. The qualified interpreter, right, is that this is their entire role is just to interpret. Again, individual who has been assessed for professional skills, demonstrates a high level of proficiency in at least 2 languages, and has the appropriate training and experience to interpret with skill and accuracy while adhering to the national codes of ethics. The qualified bilingual employee, this is a care team employee. So this could be the nurse, this could be the PT, this could be the doctor, who has also been assessed for professional skills and demonstrates a high level of proficiency in at least 2 languages. And again, bilingual employees may provide services in their target languages, an area of expertise. However, without additional interpreting training, employee will be not qualified to serve as a medical interpreter, right? So they need to have additional training in order to be a qualified interpreter. And yeah, Cassie, that is the end of my presentation.
Okay, well, thank you so much, Dr. Silvestre. I really enjoyed it. And so if you have any questions, please feel free to drop it in the Q&A and Dr. Silvestre will be open to answer your questions. Also, feel free to, in the chat, Dr. Silvestre did drop the link to that podcast. Can listen to that podcast as well.
And I'm also dropping in the chat my email address if you'd like to just contact me and have more questions. But yeah, like I hope that you've learned some things, about this issue of language access, and how important it is in order to be able to make sure that people have the appropriate care.
Okay, we got a question. Says, thank you for your presentation. Is the training to become a medical interpreter differ by state, or is it a certification that can be pursued?
It is a national certification, so there isn't like a different state by state requirements. I'm going to drop in the chat just this national certification to get certified to be a medical interpreter. If people are interested.
Okay, I'm gonna give it one more minute, just in case you all have any questions. Oh, wait, we got one more. David, okay. I see that this aspect of public health is more related to urban disparities in access to quality health care. Can we extend this to epidemiology?
100%. I mean, goes back to the class that the clinical research, right? Like they're in epidemiology, and it's not just urban, like it's all the rural, like everywhere that we find. Think back on that map that I showed, that there are, people who have limited English proficiency all over the country, not just in urban areas. In epidemiology, any kind of study that you're doing, you also have to consider what are the language needs of the populations that you're interested in. So this is absolute, and think about like the dissemination of findings, right, in epidemiology as well. This is not just limited to one area.
Well, all righty. If we don't have any more questions, again, thank you all so much for joining the Public Health Discovery Seminar Series. Again, thank you, Dr. Silvestre, for that wonderful presentation. Please feel free to email Dr. Silvestre. She did put her email in the chat, as well as listen to that podcast. Again, thank you so much, and you all have a wonderful Wednesday.
Bye, everybody.
Bye, everyone.